it is time now for this week's Health Matters with PA Lynn Szabo. How you doing, Lynn?
I'm doing good.
You're right here in the room with me. That's so
this
weird.
This is kind of exciting because this is the only option.
My social anxiety is going to kick in. So today on COVID Talk, because it's been this, with the exception of what I think maybe 2 shows in the last year and a half that you shoehorned in for some reason, and talking about how I guess this will be the new normal if we're looking toward opening up and moving beyond the pandemic and everything, how COVID will affect healthcare, but specifically healthcare for the ordinary person, not the doctor or mad scientist, right?
Yeah, I'm not really talking about like treatments and stuff like that. I'm talking about the patient provider interaction and how that's going to change, because there'll be a lot of change actually. So these ideas come from a book called Apollo's Arrow, which was written by Nicholas Christakis, who is a MD, PhD, mostly working now as an epidemiologist, not so much a clinical provider. But the book is about the enduring impact of COVID on the way we live. So a really interesting book. So the first thing is medicine has got a responsibility now to react to kind of the after effects of this pandemic. And the first and most obvious after effect that I think is going on is that there's going to be a lot of people with residual problems after they get over acute COVID.
Right. And that's been something going back to the beginning of the pandemic that seemed to be an issue, a worry, right?
So a large number of people with post-COVID problems that'll have to be managed by providers who are only slightly ahead of the learning curve on this, right? Because this is new to all of us. And there's actually, not only do we have to learn about post-COVID, but specifically how it affects neurologic, pulmonology, renal, cardiac, and psychological problems and associates. So that's that's kind of a lot of medicine.
That's that kind of tour through the body there.
Right. And not only that,
but your liver will be fine.
But the good news is you can keep your toenails. But in this response, they're really going to need specialized clinics, I think. And that's kind of great that they're realizing that, but none of them will be here. Okay. So that'll be another reason to go to specialty care out of the area. So also a lot more imaging and functional testing. So emphasis less on diagnostic stuff, but more functional. Keep people as functional as possible with what damage they've endured. So,
okay. So that way, all right. So that's like, is that ameliorative care? Is that what you call that? I mean, the functional. I mean, you're just basically you're not going to be able to fix any of these. You're just trying to
You're trying to anticipate what's going to be the problem. Try and symptomatically probably treat it early.
Okay.
And try not to be surprised by something that comes out of nowhere. So, so we also need to catch up on preventative and elective care. Okay, so all those people that didn't get their routine colonoscopies or the mammograms or the, I suppose cosmetic surgery or, anything like that. All that, there's a huge backload of that. And there's a number, disease doesn't stop just because we press pause on that. So there's going to be a large number of occult disease.
What's that?
Large amount of occult. So occult means unknown.
Okay. Is that what occult means?
In medicine.
Okay, all right. I'm just trying to... Okay.
Yeah.
I like words.
And that's going to become apparent. And unfortunately, let's say somebody who had a routine colonoscopy that was delayed for a year.
Yeah, that could be a bad timing.
That could be a delay in diagnosis. So not only are you catching somebody later, but you're catching them sicker. So that's going to be a problem. So, and also things that used to be really simple, and I've said this before, like I kind of have an obsession with sports physicals. I think young athletes who have had COVID, it looks like they're developing conduction problems in their hearts. And
conduction, you mean electrical? Like
electrical
the signal?
conduction through the heart that causes it to beat in a rational way. And there's possibility that at least even in like older, like college age students who never knew they had COVID, that they could find out that they had problems of it while they're on the floor.
Oh, wow. Oh, no.
Yeah, it's going to be bad.
Oh, geez.
And so nobody, as far as the family practice people, we do all these nice sports physicals every year, and they're usually like straightforward because 99.9% of kids are healthy. How do you screen a kid that you don't know has been sick?
Right. And that appears healthy in every other way.
In every other way.
Wow.
So, and especially since sports physicals have a degree of legal liability associated with them, I don't know what's going to happen. They're saying now that maybe they need to go to pediatric cardiologists, but wait. We don't have that here.
Yeah, what's that mean exactly? Oh my God! Wow.
Right, and how can you anticipate that?
Now, part of a sports physical. Now, a kid going high. I don't remember this being a part, but you don't get like an EKG or anything like that, right?
Well, you might be getting one now.
Yeah, exactly.
I mean, that's all kind of being formulated.
Right.
But I think a lot of family practice people haven't even thought of that. But and maybe I'm off base, but there's some evidence at the college level that it's really a thing.
Okay.
So. Bureaucratic changes. So licensing differences between states. This is going to be a good one for patients, especially here. This is a good one for this community. So when I have a license to practice as a PA in California and Oregon. So I got my California license and have re-upped it, but I think I got it originally in 1987. So, but I got my Oregon license, let's say 2019. It took about 8 months to get my Oregon license, took about 3 weeks to get my California license.
Wow, okay.
Now, accounting for differences in time because they brought computers into the system to make everything more efficient, and it didn't.
Okay.
This is going to be really good for providers to be able to cross over to borders. And it's notoriously hard for providers and x-ray techs, I think, to get licensing done in California.
So how
this will simplify that.
What will simplify it? What's the this you're talking about?
They need us in both states. And so these kind of restrictions during COVID when it was emergent, all of a sudden weren't as important anymore.
Oh, okay. So you've seen that decline
right.
in the
So they've
treating.
demonstrated that really
it's just bureaucratic.
They don't really need it.
Yeah. That's nice. Good.
So that's going to be good for us. Okay. Hopefully sick leave and Family Medical Leave Act will become more honored and possible. So when somebody is working the drive-up window in McDonald's and they're sick, they can go home and be sick.
Yeah, it's kind of carrying forward how we've been calling folks like that, essential workers and frontline workers for all of this, and hopefully that that can be carried over into the post-pandemic.
In my urgent care days, it was during the summer, so there were a lot of tourists, but a local restaurant, I watched the norovirus go through the community. So a stomach flu, a very contagious stomach flu. And I watched it because I took care of patient 0, I think.
Oh, no.
And I watched it go through the whole community.
Oh, seriously?
So,
wow.
So to say it's not a thing is coming from a place of ignorance. Anyway.
Wow.
Yeah. So, by the way, people, too, that get their second immunization, a lot of people are worried that they're going to, quote unquote, get sick, which we look at as a good immune response and easily managed. But I know my daughter, she had some blowback from her employer about having to call in sick that day.
Really?
Yeah, you have a legal ability to get that day off if you're not feeling up to it, and people should honor that.
Wow.
Yeah. So let's see. Reimbursement by Medicare, Medicaid, which is Medi-Cal, and private insurance is going to start to be a thing for virtual and phone appointments. So this is something that's been argued for a long time in medicine. Is oftentimes one of the reasons, in my opinion, that you don't get your provider on the phone very often is because it turns into a visit. And it's a visit that's not reimbursable. And so the place that we work for only makes money when our licenses are in motion. And so billable encounters. So that kind of explains why it's so frustrating. You can't just talk to your doctor over the phone.
Oh, my God.
I
did not realize that.
Changing.
Did not know that. Yeah.
Yeah, that's kind of changing now. So, and I think it could be good, and I think it could be bad. But insurance companies, and as go Medicare, so goes everybody else usually. They're starting to reimburse for that, and I think that's going to be good for patients.
Yeah.
And I think it could be good for providers, depending how it's structured.
Wow. So, and that's something that could get in the way of folks' healthcare here in Del Norte. If they can't get a provider, if they can't get a physician on the line because that physician isn't going to make a quote-unquote telehouse call.
Yeah, that's why sometimes are in the ridiculous situation where the provider is sitting right there, right next to a nurse who is on the phone with the patient and is structuring that side of the conversation so the provider can be writing notes or saying things in the background.
That's ridiculous.
I know, isn't that like 7th grade? That is so ridiculous. And I feel like
turns out the doctor likes me.
Yeah, exactly. He said that, she said.
Yeah.
So that, that kind of, we all know from playing post office as kids that's not the best form of communication. So,
Wow.
So leading in, the segue is that telehealth is becoming more of a thing. So telehealth, I've been aware of it, at least kind of on an experimental, tertiary care way for probably about 15 years. And it's been used really successfully in psychiatry, especially here in rural communities. But now I think it's going to be more of a thing. About 1/3 of visits are thought to be going to be actually telehealth visits.
Wow, good. That's good.
Which is good.
Yeah.
So now there's reimbursement for it because that was the big blocking point.
Will it be a different pay structure for physicians? Will you get reimbursed less if you're doing telehealth?
Not at this point.
Okay.
That's part of the argument.
Yeah. I would imagine they'd try to.
Yeah, because but there's a downside. So initially people really liked them. And now
not so much, it says here.
Not so much. Because, here's the way medicine is actually using them. Since there's no exam and there's very few vitals, what you're really doing is giving your educated guess, which in some cases is not really
way off.
Great medicine.
Right.
And so we have enough time on the T-vector there to know that misdiagnoses are frighteningly common.
Wow. Okay. Yeah.
So if you can't look in somebody's ear, you really can't tell them what's wrong with their ear.
And what you're doing is you're putting the onus even more. And we've talked about this as well, how you have to be your own best advocate. But in this case, not only do you have to be your own best advocate, but you almost have to be your own best physician right there. If you're going to take your own, what's your pulse right now? I don't know. Let's see.
Right.
Yeah.
Exactly. And there's a reason they call them vitals.
Yeah, right.
There you go.
So are they going to come up with a little a toolkit that you can have?
Yeah. So we have these little, I don't know, keys in our head or percentages of things. Is it more likely to be this and kind of playing the numbers? So for example, if somebody has a sore throat and it's a telehealth visit, there's criteria called the Centaur criteria that you can run in your head to kind of get an idea of whether it's strep.
Okay.
Or whether it's not likely to be strep.
Without actually just putting your eyes in somebody's mouth and looking down their throat.
There's a role for flashlights and getting really close to the camera and stuff like that.
My
but
God.
It's less optimal.
Yeah,
it's really less optimal. So, it's not the antibiotic vending machine that people thought it was going to be. I think patients thought that.
What, the telehealth would be like that? You just go, I'm sick.
Because you can't see why your ear hurts. You might as well just give you the amoxicillin. So what providers pivoted to get away from that, what they did was they turned it into a screening tool to get into the clinic.
Yeah.
So
and it seems almost like it's adding another layer that you have to get through in order to get to healthcare.
So that's 2 billable visits.
Oh, jeez.
Yeah, see, so I don't know, not feeling the love there myself. But anyway, here's a bright spot. And this is kind of a horrifying, but
it's a horrifying bright spot.
It's a horrifying bright spot. So there's things called iatrogenic illnesses and injuries and nosocomial illness and injuries. So iatrogenic is mistakes that happen in the course of medical procedures that cause harm to the patient.
Okay.
So
like leaving a sponge in?
Ones would be amputating the wrong leg.
That would be.
Or leaving a surgical tool inside of abdominal, in the abdominal cavity. And nosocomial illnesses and injuries are illnesses that are acquired in the hospital that are not the result of mistakes. So somebody goes,
infection?
Yeah, somebody goes in the ICU and unfortunately is given antibiotics for pneumonia and gets C. difficile, which is a bad, Clostridium difficile is a bad diarrhea problem. So because there were less people hospitalized.
Oh, okay.
In most hospitals.
Fewer of those things.
There were fewer mistakes and unfortunate occurrences.
That's kind of a bright spot.
Yeah, this is good because these two types of injuries or illnesses are responsible for 50 to 100,000 deaths yearly.
Wow.
Medical mistakes or wrong place, wrong time occurrences.
Oh, my God.
I know, isn't that horrifying?
That is horrifying.
That is horrifying. So by deferring some of the selective surgeries, people were able to dodge mistakes or bad timing. So that's kind of good. That might start to change, though, as people start getting more elective stuff done. So the sad thing is that COVID's probably never going to go away. So in about 3 years, it could be, what's going to happen is the virus is going to kind of evolve to not killing us as much. Okay.
Is that what happens to?
It's going to fine tune it. It's probably not a cognitive function, but
well,
it's just kind of a natural selection byproduct.
Because it'll. Oh, okay. I mean, it seems like is that. Wow. Okay. Here's a big question. And I know you got a place to be, so.
It's okay.
So is that par for the course for diseases like that and evolution, because you don't want to kill your host?
Right. There's still evidence in seasonal flu of the flu epidemic of 1918.
Genetically?
Yeah, genetically.
Wow.
And that's and actually, they're looking back in the late 1800s. They think there was actually a different COVID virus that went through and killed a lot of people in the community. They always assumed it was an influenza, but now that they can get old specimens and stuff and get the genome, they're identifying it as a SARS virus.
My God.
Kind of interesting.
My God. Wow.
So we've been through this before. In fact, we have evidence in our DNA of old viruses that are...
And human DNA?
Human DNA that are like millions of years in our DNA. So, yeah. So we'll kind of get over it, but it'll never really go away.
Right.
And I don't think there's really going to be a herd immunity. They're talking this week about San Francisco being close to reaching herd immunity, but I think what's going to happen is that doesn't take into account variants of concern.
Sure.
And they're naming them differently. So the variant of concern, India, is now called Delta variant.
Okay.
And there's 6% of the cases in the United States right now are Delta variants.
Okay.
So it's going to be a matter of time. So people who are unimmunized are especially vulnerable to a more potent, more transmissible virus coming into the community right now. While those of us who are immunized, 91% likely to be okay.
Yeah.
So that should scare y'all.
Is there any idea that like any indication that COVID? Okay, so COVID. I mean, looking at it moving forward, it's going to be like the flu, right? We're just have to get a new shot every year, I would assume, some sort of booster.
It'll probably be a messenger RNA vaccine or a mixture of two vaccines. So they're kind of working on that.
So has it mutated as quickly as influenza mutates? Do you know this?
Oh, yeah.
Has it? Okay, so that's the kind of...
Yeah, you can go to New Strain, which is, a website, and you can see all the mutations. It's just a mass of squiggles.
Wow.
Yeah, it's really... And you can watch it over time. It's, like, incredible.
Okay, next question.
Yeah.
So will this ever lead coronavirus and the steps forward with vaccination with the coronavirus, or this version of this coronavirus, the SARS virus, will this ever lead to a cure or a more effective treatment for the common cold?
Yes.
That's what I thought. Because it's the same kind of virus, right?
Common colds are coronaviruses. So yeah.
So if you have something that's attacking a spike protein, a vaccine that's doing that, for COVID-19, could it conceivably also immunize you against a common virus? The coronavirus cold?
Yeah, that might be interesting to see if that starts happening.
And I know that, and another thing that won't be a downstream effect of COVID going forward, unfortunately, is we essentially had no flu season this year, right?
Yeah, it was so. It
was that good?
Like it was 2020, and we watched it. It was a horrific one. All those people that think they were sick in February 2020 that were certain they had
that
COVID,
was the flu.
That was a horrendous influenza, and it stopped in 4 days. Wow. When they shut down, it was like, and actually, there was only one pediatric death that influenza season. Usually, there are thousands.
Wow. Yeah, I'd seen something about just the death rates for influenza just kind of not being off the chart. Well, off the charts in the sense that they didn't even make the charts.
Right.
This year,
I didn't even look at the flu map this past winter because there's a CDC flu map, and you can actually, it usually starts in Guam, actually. I don't know why, but it starts on the East Coast and kind of trudges west.
In Guam?
I know. It's Guam usually gets the first cases. I think it's because there's probably a lot of travel there.
Wow. I guess, it's a hub, right? So between East and West,
right.
Sure.
And then it starts like New York City, East Coast stuff, and then it trudges. But I didn't even look at it this year because...
Yeah, why? Why bother?
It was cricket sounds.
That's why. That's excellent.
Yeah. So there's going to be a lot of cool things happening and a lot of not so cool things happening. But masks are here to stay. I imagine, let's say COVID disappeared tomorrow, if we could do that. With what we know about masks, that could really help influenza.
Yeah.
That could also help pertussis. I mean, some people will remember the pertussis outbreak in Del Norte County in 2010, and how many people got sick. That was awful. The children, there was vaccinations in the school, and there wasn't a peep about it. 2010, that wasn't that long ago.
Wow. Yeah, see? Oh, my God.
Yeah.
And you kind of skipped over, I think we may have glossed over this point, but you made a point here in your notes. Unimmunized people will drag this out.
Oh, yeah. Let's go back to that.
Yeah. Because the reason that we're sitting here in what is it, June of 2021, talking about how the pandemic has played out and all of this stuff is because we didn't have the wherewithal to deal with it, say, I don't know, like New Zealand. And New Zealand's a special case because it's an island and all this stuff.
Right.
But because we couldn't as a society deal with it in March of 2020, that's why we're having this conversation here today.
Well, that and people choose not to get immunized. So somebody asked me if she still had to wear a mask after her second immunization, why did she bother getting immunized? So the answer is because all the people didn't get immunized. And, it's still a problem.
I had this meme went around yesterday, and first thing I did with my day yesterday was like, respond angrily to this meme. And it was somebody had posted, a cashier at a supermarket behind the plexiglass.
Which is useless, yeah.
What useless in what way?
It doesn't help. And the air circulates around the
plexiglass. Yeah, it's not.
Yeah, that's kind of a pretend measure.
Okay, all right, good. Well, people were chiming in on this thing about how the plexiglass is saving you from COVID, the COVID that this clerk has as she breathes all over your groceries. And it was just just the surface, like that's where the contamination was going to be.
Yeah, you don't get it from eating stuff.
Not even or handling stuff, right?
And I'm telling you don't have to like wipe off your million packages of toilet paper.
No,
with chloroseptic.
Exactly. So it just even this late in the game that people are still not up on the facts, haven't been following along, haven't been playing along with the rest of us. That's not how it works. Because
I think the plexiglass is worse because it decreases ventilation. And ventilation is the unsung hero of this epidemic, actually.
Oh, just moving the air out, sure.
Yeah, just moving air around, opening windows, stuff like that. Being outside. I mean, we don't talk about it specifically. We do in the papers and stuff, but we don't talk about it to people specifically.
About ventilation?
Yeah, but we suggest maybe a party outside is safer than
that's all
a party inside.
But that's always been, it seems, maybe we don't consciously highlight that, but that's been, outside was always okay.
Right, so the plexiglass barriers decrease
droplets, I would imagine, right?
Yeah,
like no one's
but not
spray
aerosolized, so that actually concentrates.
Oh, geez, really?
So it's not a good thing. Anyway, but we digress.
We do. As I often lead the charge in digression. Where were we? Unimmunized people will drag this out. Okay, there we are.
They will. Yeah. So get your immunization.
Oh, geez. Because it is not all about you.
Yeah. That's well said.
Thank you. Yeah. It's something people have told me my whole life. So I finally internalized it. Okay, so right here, so I don't want to jump ahead.
Actually, I think we're done.
But luckily, mRNA
mRNA technology, you're going to see it. It's going to be the way we make flu shots. It's going to be the way we make shots for Ebola. It's going to be the way, hopefully, we make shots
cancer.
For It could be.
Mm-hmm.
It has,
Kinds of cancer?
It has been used for that. Malaria, one of the biggest killers in the world. Unfortunately, not here, so we pretend like it's not really a thing, but it is.
Yeah.
So, yeah.
That's true.
Yeah, messenger RNA. Thank you, persistent Hungarian woman. Who needs to have a better name than that? Caitlin Keiko, I think, is her name. So, but my Hungarian's a little rusty.
What do you mean, Szabo?
Yeah,
what do you
I
mean your
know.
Hungarian's a little rusty?
It is. I know some, but nothing that isn't really a sentence.
Oh, well, I know there's some Hungarian there because you've got an S and a Z right next to each other in a word. That's right. That's why, like I said.
When I got my DNA done, it's actually more Romanian.
Poser.
I know, totally, all my life.
Going to revoke your Magyar card.
I know, that's true. It was kind of traumatic for my dad. But anyway.
That's okay. We did. My mom did DNA stuff, and I grew up with like a 16th Native American, like Cherokee. I even met my Native American great-great-grandmother when I was a little kid. Comes back, the blood comes back, the DNA. Nope, not a drop. I don't know who that woman was.
Well, I actually think things evolve. One thing I've noticed about mine is that, I used to be Italian, and now I'm not. So, so I think as they get more data from different groups of people, especially Native Americans, they don't have a lot of data from that group. So I think things change.
Wow.
So you might go back to being Native American again in some small sense.
Oh, I can't take this.
I know. It's an identity crisis.
One day I am, one day I'm not. I don't know.
I know.
Lynn, thank you so very much, and I really enjoy it when you come into. If you were looking to record on the phone last night, and I responded to enthusiastically about having you in the studio again, I apologize for that. It's nice having you in the studio.
Yeah, all of a sudden it occurred to me I could be here. I was in clinic late. Laying hands and stuff. So here I am today.
All right, off to your Zoom meeting. Continue to do good in our community, and thanks for this week's Health Matters. We'll see you next week.
Thanks.
Lynn Szabo, everybody, give her a hand.
Yay.